How many of you have seen a displaced scaphoid fracture? So not a lot of them have seen a displaced scaphoid fracture. Okay. Right. To go some basic aspects, most of the time it's due to a fall on a hyperextended radially deviated wrist. Okay. That's the commonest fracture that you see in the carpal bones, scaphoid fracture. Okay. About 60% of carpal fractures are involving a scaphoid bone. Not that common if you see the incidence, 38 out of 100,000. I don't see this injury very often in children. If you diagnose scaphoid fracture less than 10-year-old, you probably not right most of the time. And 80% of the fractures involve the waist area. You see the scaphoid can divide into 3 parts, which are completely eliminated. 80% of them come into the waist area. Okay? And it's like, if you remember talus, it's a bone which is fully covered with the articular surface. Same like that, scaphoid is also covered, almost 80% has got articular surface. Okay? And some studies have shown somebody has negative ulnar variance, they have a slightly higher propensity to get a scaphoid fracture. And on an overall, always worry about AVN. In few bones, one of them is scaphoid, and scaphoid about 12% is a rough incidence. Okay. So if we location the fracture wise, some studies say waist is 65%, some of them say 80%. Okay, but waist is the commonest anyway. So, proximal 1/3 is next, and distal pole is least. Anyone know about the blood supply of the scaphoid? Please. One of you can tell it. One taker? No?
No wonder there is avascular necrosis. There is
Yes.
no blood supply.
Yes. Okay. It comes from radial artery. Okay. So main branch comes from the dorsal side. Another comes from the volar side. The one coming from the dorsal side is the most important one. Goes right up to the distal end and comes towards the proximal side in a retrograde fashion. So it supplies almost 70 to 80% of the scaphoid. Run from the volar side, comes from the superficial palmar branch, superficial palmar arch, okay, and it goes towards volar and supplies the distal 30%. Okay, and these are all end arteries. It's intraosseous, so the risk of AVN is much higher, more proximal. So if you have a fracture in the proximal 1/5, you're almost guaranteed AVN of about 90 to 100%. If it is proximal 1/3, it's about 33%. Waist is less, and if you go to the distal pole, virtually unknown. Okay, so the blood supply, if you see this diagram, this is a very common question in the exam. They will ask it every time. This is from the dorsal side. You get almost 70 to 80% of the proximal aspect is supplied from the dorsal side. From the volar side, you have the distal side is being supplied from the volar side. It's only about 20 to 30%. All of them are end arteries. Okay. So the blood supply here is very tenuous. Any fracture happening over here, you got a very high risk of AVN. Over there, better. Here, there's no risk of AVN. Okay. So we see this. There's a gradation of the blood supply loss as you go from distal to proximal. So when you see a patient with history of fall, what will you examine? Obviously, you have seen scaphoid fracture. Tell me what is the thing you see in a scaphoid fracture, a suspected scaphoid fracture. Anyways. Please, one sound loud, please. Yeah.
Fullness at anatomical snub box and tenderness.
Okay, so anatomical snub box, where is it?
It is.
So, EPL, APB. In between, you have a nice fossa, that's anatomical snub box. And what else would you see?
Fullness and tenderness.
Pain, tenderness, and scaphoid tubercle, where is it located? It's in the volar side. You can just feel it. Everybody can feel the scaphoid tubercle. Just over a very prominent area in the corpus, okay? The scaphoid tubercle. If you press there, you have tenderness. And then axial compression. Compress on the thumb. Somebody having a scaphoid fracture will definitely have pain. You can do pinching. With the pinch, putting pressure will cause pain. So, and pronation also can lead on to pain. So these are the initial features that you can see when somebody is suspecting a scaphoid fracture. So you always ask for X-ray. What are the views that you ask for? Okay. Normally, you keep in the mind, if you do radial ulnar deviation, radial deviation, you can feel the scaphoid tubercle moves. Can you feel yourself? When you do ulnar deviation, the scaphoid actually extends. When you do radial deviation, it flexes. So to get a profile view, you do an ulnar deviation AP and lateral and do 45-degree pronation and supination view. Okay? The 4 views will constitute for the X-ray of the scaphoid, and about how much time you find the fracture is about 70%. Okay, it's got 70% sensitivity only X-ray. So if you can't find a fracture in X-ray, but a patient has got tenderness, all the features that I told you earlier are there, what else should you do? What would you do then?
We'll sit a scaphoid caster and we'll call him after 10 days.
So you put a plaster and call him back in 10 days. So you take the plaster out in 10 days, what would you examine?
Then we'll take again one X-ray, sir. And most of the time it...
Okay, if you do X-ray, you can't say anything, but clinically, what you would examine? So you look for the same symptoms and signs again. Look for tenderness again. So if they are tender, what will you do? If they are not tender, what will you do?
If it is tender, then we'll continue the immobilization.
Okay, yeah. So if you have tenderness, then you still have a suspicion there could be a scaphoid fracture. It's not being seen in the X-ray. Okay. Then you go for either further investigation, or you could just go on for a plaster. Okay, for another 4 weeks. That's also completely acceptable. But we can debate about keeping a patient immobilized for extra 4 weeks. So you can straight away go for an investigation. Okay. What investigation you could go for further?
3D CT scan.
Huh? MRI or bone scan. So you have only 3 available: MRI, bone scan, and CT scan. Okay. So bone scan, how much is accuracy? Bone scan has got a very high sensitivity, which means it will identify if there is a fracture. Okay, but it's not specific. Okay. So you can do a bone scan at 2 each stage, and if there is a high uptake, you probably indicate there is a fracture. Okay, but specificity is very low. Okay, it's 65%. Okay. So in order to identify even more better, what will you do? So MRI scan has got more sensitivity and specificity also. Okay, so you can actually more or less pinpoint where the fracture is. There will be some minor changes. And CT scan is also used to more or less to assess the type of fracture, and also if you are following up the patient to see whether there is union or not. Okay, so MRI scan has become almost more than 95% sensitivity and 95% specificity now. So how long would you keep you on a plaster for a scaphoid fracture?
3 months, sir.
12 weeks.
Yes, good, yeah. So if somebody gets a distal pole fracture, how long would you need it for? So around 6 weeks is enough, okay? Waist?
8.
Okay. Proximal pole will be even more longer, okay? You try to keep until 12 weeks. But you have to make sure before whether the fracture is treatable non-operatively or not, before you're going into the decision, okay? If it's an undisplaced fracture, you probably are going to the non-operative route, then you're thinking about treating like with a plaster, okay? So, anything that you should know about, normally they ask classification in the exams nowadays anyway. So, heard of Herbert classification?
There are 6 classifications, sir.
Okay. So, how do you determine the stability of the scaphoid fracture? How much is acceptable displacement in a scaphoid fracture?
1 mm.
So, more than 1 mm is considered as displaced scaphoid fracture, okay? And angulation, any angulation is not acceptable in scaphoid fracture. Any comminution is not acceptable. Okay. What is the fracture configuration? Not a good one, which is a good one? If you have a vertical or oblique fracture,
That is good.
they have a high propensity to get displaced, so they are unstable fractures. Okay. So comminuted, vertical, oblique, and more than 1 mm displacement, any angulation is not acceptable in scaphoid fracture. Okay. So Herbert classification is actually very simple to remember. A and B are the one which are the important one. C and D is just C is delayed union, D is non-union. Non-union is considered if anything not healed after 6 months can be called as established non-union. Delayed union somewhere in the range of 4 to 6 months. Okay, it's delayed union. So A is acute stable fracture, where if you see anything in the distal pole or an undisplaced waist fracture, it's an acute stable fracture. B is unstable fractures, which is acute still. Okay, so you have a fracture which is displaced, or an oblique fracture, or a proximal pole fracture, or this is the most important one, transcaphoid perilunate dislocation. So where the lunate is full dislocated, scaphoid is fractured also. It's a proximal carpal row injury. Okay, greater arc injury. If you see this, it's almost an indication for fixation. That's the only definitive indication for surgical fixation. There's no doubt about it. Everyone agrees with that. Okay. So that's the criteria of displacement. Okay. This will come more in when you talk about carpal instability. So if you see an unstable fracture, the non-union rate is around almost 55%. So unstable fractures come into this category. More than a limited displacement, angulation, vertical oblique fracture, comminuted fracture, they all come under unstable fracture. Okay. So standard treatment, what we do is putting a plaster. It's a big debate about whether to include the thumb or not. For your sake, be aware it needs immobilization. You can find evidence for both. If you look at the literature, you can find evidence for not protecting thumb, unprotecting thumb. Okay. So both answers will be acceptable in the answer, definitely. Okay. So distal third will heal in about 6 to 8 weeks time. Middle third, like in waist, will heal in about 12 weeks, and you put it up to about 23 weeks for a proximal pole. Any displaced scaphoid fracture, treatment is surgical fixation. Okay. So if you decide to operate, how would you approach? For all fractures?
For
Proximal pole.
Okay, why?
because the main arterial supply is from the dorsal side.
So basically you mean if you go from the dorsal side,
chances of diversion to the main arterial supply is more.
so if you go dorsal side, you're going to damage more blood supply.
For proximal poles, the fixation is
Yeah, basically for access of the proximal pole is much easier to the dorsal side. Okay, application of metalwork is also easier from the dorsal side. From the volar side, you can treat for all the waist fractures. Okay, it preserves dorsal blood supply. And proximal pole access actually is very difficult through the volar approach. Hence, you do the dorsal approach for those. And volar approach will disrupt carpal ligament. How do you do volar approach? The same like Henry's approach. On the bed of FCR, where you go more distally, a curved incision, straight on the scaphoid tubercle, straight on the scaphoid. Be aware of the radial artery and the dorsal branch of radial nerve. Okay. So for proximal pole, you do the dorsal approach. The screw positioning will be slightly easier if you go to the dorsal approach. But downside is not friendly to blood supply. So you got to pros and cons about these things before you go on. So surgery. As any surgery, you have problems like infection, injury to nerves, tendons, and hardware failure, where K-wire migration or screw failures. But if you do your medical surgical technique, most of the time you can avoid surgical complications. Let's just go and do some complications that is commonly we have to know about, avian and non-union. Okay, I'm not going to go in detail about snack and degeneration because there's a talk on carpal instability later on. Okay, so avian, again, investigation X-ray, MRI or CT scan. Only in advanced stages you see all these findings, sclerosis, collapse and fragmentation. But MRI is a bit more specific to identify avian, where you see hyperintex signal in both T1 and T2 images. And CT will be useful for identifying sclerosis and also see the trabecular pattern of the fractures. Okay. So, if you have a scaphoid non-union, I think, I don't know how many of you know Girula's arc.
Lesser and
So Girula's arc is basically, these are 3 lines that's been drawn. It's a proximal carpal row and a distal carpal row. You can actually form like a little U. Okay. If there is any interruption in the proximal or distal carpal row, it means the X-ray is not normal. That's what it says, Girula's arc. Okay. And so you have to keep in the mind about the biomechanics of the corpus. Proximal carpal row is a movable part of the wrist, corpus. Distal carpal row is a stable part. Okay. Anything in the radial side has got a flexion moment. Anything in the ulnar side has got an extension moment. So if you disrupt the proximal carpal row, anywhere from scaphoid to trachea, the radial structures will flex, ulnar structures will extend. So you keep this concept in the mind, it will be easy to understand the DC and VC deformity. Okay? If you fracture the scaphoid, you'll have the distal pole will flex, proximal pole will extend, so you get this humpback deformity. But if you rupture, instead of fracturing the scaphoid, if you rupture scapholunate ligament, then you will have a Scaphoid will flex, lunate will extend. You'll get a DC deformity. So if the lunate is dorsally angular, it's called DC deformity. Okay. If you come to lunate trachytrum, okay, if there is LT rupture, lunate trachytral ligament rupture, lunate will flex, trachytrum will extend. So lunate will show a VC deformity, polar intercalated segmental instability. So just keep this concept in the mind. You can apply very easily in the proximal carpal row. Okay. So if you have a scaphoid non-union, you'll see the humpback deformity because the distal one has to flex, the proximal one has to extend. Okay. So treatment options for a non-union and AVN. Okay. So anything in the waist, you probably know there is some blood supply, so you can think about bone grafting and fixing it. But anything proximal, the blood supply is tenuous, think about a vascularized procedure. You don't have to go in detail about it. There are a number of vascularized bone graft available. Okay, just for the exam sake, you should know the basic algorithm. Waist, distal to that non-union, you treat with graft, which is non-vascularized graft. Proximal to that, you have to think about vascularized graft. Anyone who is having non-union and consequence of non-union like degeneration, then you are thinking about salvage procedures, which is either intercarpal fusion, carpectomy, scaphoid excision and four-corner fusion, and these are the advanced ones. Don't worry about these, okay? But you should know about at least scaphoid excision, four-corner fusion. This is the one which is commonly done in proximal to carpectomy. So keep this. The basic algorithm is location of fracture, vascularity, and degeneration is there or not. Location is distal. Think about just bone graft and fixing. If it is proximal, vascularized bone graft and fixing. If it is degenerative, like salvage procedures then. Okay? So, right. Any questions about scaphoid? We'll go to TFCC in a minute. It's even a weird topic anyway, TFCC for all of you.
So how do you assess displacement in a plane X-ray?
In plain X-ray, if you can see the fracture line most of the time, anything more translucent probably is displaced. You know, difficult to find a fracture line is undisplaced. We see a fracture line very clearly, and any change in angulation is displaced. Yeah. So basically, you have very little tolerance to accept any displacement.
How do you assess displacement in a lateral view? We take a
In the lateral view,
rotation.
you can actually, you should be able to see. There's a picture here. So this line is scaphoid, okay, and that's the lunate. Okay. You will see this fracture line should be somewhere here. So you should be able to see that. Any more? Let's go to TFCC. How many of you know what is TFCC? Anyone knows about TFCC? Is it a one structure or multiple structure?
Multiple structures.
And what are they?
Ulnar collateral ligament, dorsal and polar medial ligament, and menisci homologue and the articulated disc.
Nice, thank reading. Yeah, it's a good homework last night. Okay, TFCC. As you remember about the name Chanley in hip replacement, for TFCC you have to know this name, Palmer. He's the guy who first found out the TFCC complex and its function. Okay, just in a simple term, remember like meniscus in the knee joint. Whatever the function of meniscus in the knee joint, has got a similar function for the wrist. Okay, TFCC. So there are like almost 6 structures which constitute triangular fibrocartilage complex. Okay, so there is it's actually arranged from the ulnar styloid base and goes to the ulnar aspect of the distal radius. Okay, so you're able to see from this here. Yeah, and you see a meniscus homologue which is here, and you see a ulnar trachytral ligament, ulnar lunate ligament, distal radial ulnar ligament, central disc, and triangular ligament. On top of that, there's ECU, okay, which is there, extensor carpi ulnaris. Actually, there's a pulley that goes around TFCC, covers the ECU. So it's also considered as a part of the TFCC complex. Okay. So I think one has to be really clear about what is TFCC and where it is. Okay. And the function is, if you see it, it tries to, this is the ulnar aspect of the corpus, this is the radial aspect of the corpus. It hangs the ulnar aspect of the corpus to the radius and ulna. That's its function. It hangs it there. Okay. So it's a major ligament stabilizer of the distal radial ulnar joint and also the ulnar corpus. Okay. So what is the function? It's similar to meniscus, okay? It's a shock absorber. So it forms a gliding surface during the movements of the wrist joint, flexion, extension, and translational movement, okay? It forms a nice gliding surface and allows a stable rotational movement, and it suspends the ulnar corpus to the dorsal ulnar face of the radius, and it's a good shock absorber. I mean, if you take the meniscus in the knee, what happens? Confirm arthritis, isn't it? Been clear documented studies which have shown that 10 years time they all have degenerative changes. Exactly same thing happens in TFCC also. If you take the TFCC completely, for example, okay, and leave the patient without TFCC, you will see degenerative changes happening in due course of time. Okay, so it's almost similar function like meniscus. Okay, so patients come with ulnar side wrist pain. One of the differential diagnoses for ulnar side wrist pain, okay, of a lot of things, ECU tendonitis is one of them. The commonest thing is TFCC tear, okay, and clicking. And they are also sometimes associated with intra-articular fracture and extra-articular fracture also. The incidence is around this 35 and 53%. Okay, but you see a lot of ulnar styloid injuries when you see a distal radius fracture. The tip of the ulnar styloid breaks. Actually, that hasn't got any correlation to the TFCC, though, because the TFCC is actually attached to the base of the ulnar styloid, not to the tip. So just breaking of the tip will not cause any injury to the TFCC. Be aware in that mind. Okay, but if a badly displaced distal radius fracture can have implication on the TFCC. So, if a fracture has got an ulnar positive variance more than 4.6 millimeter by the, and also more than 12-degree angulation, there is a higher chance of having a TFCC injury along with the distal radius fracture. Keep it in the mind, okay? So that's why when you see a patient with a distal radius fracture who is angulated and has got ulnar positive variance, you try, where there is radial shortening, okay? You try to go and reduce it to the perfect anatomical position, okay? Okay. Natural history of TFCC is actually everyone naturally start degenerating after third decade. Okay. By fifth decade, we have seen that most of the TFCC is abnormal. This is done by the cadaveric study in a large group of patients, more than 120 patients. Okay. And those who are, they took the patient from like 20-year-old to 94-year-old and found out almost after the fifth decade, most of them have some TFCC changes anyway. Okay. So again, pronated hyperextended wrist, falling, and the power drill injuries actually I have seen a couple of them actually, where you use a power drill. The drill turns, instead of drill turning, your hand will turn. If your hand rotates quite severely with the power force, you probably get a higher TFCC injury. And you see commonly in the sports players, golfers, tennis players, you see due to the repetitive movements, okay? And along with other fractures also you can see this TFCC injury. So some of the important things that you have to remember, what happens normally in the wrist, okay? If you're doing a grip, any grip movement increases the ulnar variance, any pronation increases the ulnar variance. Okay. So ulnar normally, which is neutral, will become positive when you're doing the pronation. That's normal for everyone. Okay. Same way when you're doing gripping something, ulnar slides in the front. Okay. Supination actually decreases ulnar variance. Okay. And in the same way, ECU excursion, because TFCC and ECU is interconnected, ECU excursion can cause TFCC problem also. So be aware of that. So then you know, the TFCC is ruptured, okay, normally the force, as in leg tibia takes the most force, and ulnar fibula takes the less force. In forearm, 80% of the force goes to the radius, 20% only goes to the ulnar. If the TFCC is ruptured, then the biomechanics get altered, and they started having more force going to the ulnar instead of radius. They start developing degenerative changes. Okay. So features will be ulnar side wrist pain, clicking, and mechanical symptoms that worsens with activities and improves with rest. Okay, so it's like meniscus tear, where you have a tear inside the TFCC. When they are moving it, you're going to have the flicking movement and also pain, mechanical symptoms. Okay, so there are certain tests that usually, very unlikely to get a TFCC tear patient in the exam. But if you get it, if somebody comes with ulnar wrist pain, then the thing that you should do is the ulnar deviation in the neutral position. If they get pain, you should think about TFCC. You can do some rotation movement also at the time. And if they develop clicking, that also indicates about TFCC tear. TFCC and DRG instability can go together. So you can look for DRG instability. So hold the distal radius in one hand, one finger, other finger will the ulnar. Try to do shuckable movements. Okay? If there is more displaced movement, usually always compare the other side. Some of them will have a higher ligament instability, and they might be already having DRG instability physiologically. Okay, so you should always compare the other side to make sure it is a pathological. Okay, piano key sign is most into the rheumatoid also. If you do the pronation, you see the ulnar head ballotting out. That's piano key sign. Okay, and also all the TFCC also look for lunar-tracheal interval tenderness, because further stage of TFCC tear is going to be affecting the lunar-tracheal ligament perforation. Look for lunar-tracheal ligament tenderness, which is just on the ulnar side. Okay, and look for ECU tendon whether it's subluxing or not. These are certain features that you need to look into in specific to TFCC tear. So, diagnosis, X-ray doesn't give much information apart from ulnar variance. Okay, whether it shows either a positive variance or negative variance. Wrist arthrogram has become more of historical now. Not many people are using it, but it has got some diagnostic value. Okay, MRI scan is much more sensitive and specific. Okay, 80% sensitivity. You do arthrogram, so inject gadolinium dye and do the MRI scan, and you can see the TFCC tear. Wrist arthroscopy is becoming gold standard. Okay, so one has to know about this trampoline sign. If in case we are asked about wrist arthroscopy, what will you see? So if somebody is able to have a bungee effect, or put a scope in and put a probe and have the bungee effect, it means TFCC is intact. Okay, so TFCC has got a perforation anywhere or a tear anywhere, you won't have the bungee effect. Okay. If you remember that point, that's more than enough for the exam. Otherwise, it's easy. It's very useful to identify the size of the tear. Is there any unstable flap, synovitis? If there is a ligamentous lesion, for example, if there is a scaphoulonate ligament damage, it can be easily seen in the wrist arthroscopy. So, it's a classification by Palmer. So, class 1 is trauma, class 2 is degenerative. Okay. So, trauma, we have a central perforation, as if like here. Okay, central perforation. That's A. If you have attachment from ulnar side, it's B. Distally, it's C. Radially, it's D. As simple as it is. Okay. So, A is just central perforation. B is ulnar side. C is distal side. D is radial side. As simple as it is. Okay. This is for the trauma. Okay. Patient coming in after the trauma. The one we are seeing after the 4th and 5th decade are degenerative. Okay. They will have a wear. It's not a tear. It's a wear. Okay. And there will be lunate or ulnar chondromalacia. If they have perforation with lunate or ulnar chondromalacia, which is changes in this side, okay, lunate and ulnar chondromalacia. If we have along with that LT ligament perforation, so ligament between these two, if that is also perforated, that's why I ask you to test LT ligament tenderness during examination. Okay, if it is perforated, then they can also cause lunar-tracheal instability. That's D. E is whole ulnocarpal arthritis. Just give an outline of how we treat it. Okay. So anything you see TFC's initial treatment is conservative. Okay. You can immobilize them in a plaster with a slight flexion and ulnar deviation. Put a short arm cast for 6 weeks, and then you can use a splint for another 4 to 6 weeks. So about 8 to 12 weeks. If they respond, there's no further treatment. Okay. If they don't respond, then go on for the surgical treatment. Okay. Usually the A variety will respond. Okay. Further may not respond. Natural history, if they have ulnar positive variants, they all worsen in about 2/3 of time. If a neutral ulnar variants, they probably didn't worsen over the time. So just give a quick outline. If you have a traumatic tear, 1A, which is just perforation, okay, we just debride it, arthroscopic or open. Either way it can be done. Okay. BCDE is avulsed from one side, so you got to go and repair it. Okay, you can do either open technique or arthroscopic technique. Open technique, common occurs between 4 and 5 extension compartments. Okay. And identify the tear and fix it with the whatever available anchors, you know. Okay, Mitec anchors are available. There are so many ways you can fix it. We just need to know the principle. Okay. Wrist arthroscopy also you can do the similar thing. Okay. Fixation methods are not become much more popular. I think it's coming up slowly in the wrist arthroscopy also. But debridement is definitely much better with the wrist arthroscopy. It can be done. So, in degenerative type, we have ulnar positive and symptomatic. Then you think about ulnar shortening. Okay, so there is a identifiable pathology inside. So, where is the ulnar positive variance? Then you might as well reduce the ulnar length that can help for reducing the stress going through the TFCC. So you can think about that in 2A and 2B along with ulnar positive variants. Okay. 2C or D, where you have lunar tricutal ligament instability also. There also you can think about ulnar shortening, because ulnar shortening actually indirectly can tighten the lunar tricutal ligament also. That can contribute to some stability. So that is one possibility. Okay. Those who are having 2E, who are degenerative, are only salvage procedures. Kapanji procedure, direct procedure is excision of distal ulnar, okay. Limited ulnar head resection. So these are the palliative procedures. So just to know about this, can be asked in ulnar shortening, osteotomy can be asked in the exam. Okay. So it's an extra articular procedure. So you're not touching the TFCC at all. So you're not causing any further damage if there is. You're not causing any damage by surgery to the TFCC. Okay. It maintains the origin and insertion of ligamentous tissue and capsule, forming the peripheral aspect of TFCC, and it actually tightens the ulnar carpal complex, including the LT ligament. Okay. And because it's outside the joint, it's a less painful procedure than an arthroscopic resection. Arthroscopically, you can resect the distal ulna also. It's actually less painful procedure than that. These are the advantages of that. Okay. So I think if you know this, you can easily surpass through the TFCC. Any questions, I'm very welcome to answer about it.